Welcome to this video presentation on immediate skin-to-skin contact, separation, and mother-newborn couplet care, also for sick and preterm infants. I am Stina Klemming, a senior consultant in neonatology and NIDCAP trainer at the Lund-Malmö NIDCAP Center in Sweden. I have consent from parents for all pictures and films. I do not have any financial disclosures. I am a member of and a NIDCAP trainer in the non-profit organization NIDCAP Federation International. Objectives for this talk are to go through the updated recommendations for early and now immediate skin-to-skin contact, to briefly touch on the evidence, including our results from the immediate parent-infant skin-to-skin study, IPISTOSS, present clinical practice with requirements of feasibility and safety for immediate skin-to-skin contact and mother-newborn couplet care from our experiences in Sweden. Being close and in skin-to-skin contact is instinctively right for all parents and newborns directly after birth. Biologically expected experiences during the early sensitive period of the first hours and days of life should be presented for all newborns and their parents. Immediate mother-infant skin-to-skin contact, smelling, connecting, suckling, and getting breast milk by mouth. This also means important processes of stress regulation with lowered cortisol, sensory stimulation with increase in oxytocin, nutrition through prolactin and instinctive behaviors, microbiome maturation and immune competence, adaptation and stabilization of physiological systems. From the strong evidence there is for skin-to-skin contact to be used as early as possible and for as long as possible for newborn hospitalized infants, the World Health Organization announced these updated recommendations for the care of the preterm and low birth weight infant in November 2022, and with the even stronger position paper and implementation strategy for scale-up of KMC in May this year. All infants above 1,000 grams should have skin-to-skin contact as soon and as early as possible, and continuously for as much as possible with a minimum of 8 hours per day. The WHO also have counted on the anticipated impact of annual prevented death globally, with the current coverage of KMC, which is far too low. 10,000 newborns are saved each year. If we had a 60% coverage with scale-up implementation of KMC for small infants, for stable small infants, 150,000 small babies could be saved, and 250 if we add the impact of community-initiated KMC. Here are examples of a mother giving birth in the war zone of Ukraine and a mother in the sub-Saharan Africa. Adding immediate KMC with 80% coverage and with the 25% decrease in mortality, as seen in the IKMC trial, a total of 400,000 small and preterm newborns in low and middle resource settings could be saved from an unnecessary death each year. Lowered mortality in low and middle resource settings is a strong reason to implement immediate skin-to-skin contact, but there are many strong reasons for us working in high resource settings to find new ways of working to implement these strategies of separation for better well-being and better outcomes for babies and families in all settings around the world. With this statement, the WHO also envisioned for healthcare services to be reorganized around the mother-newborn diet as an inseparable center. This is also for all newborns in all different settings. As important parts of the concept of infant and family-centered developmental care, both immediate skin-to-skin contact and separation should be available for all babies and families all around the world. Most things for most babies can be done without separating baby and mother. Here, nasal CPAP therapy and a peripheral line insertion in a baby boy born week 31, and so far during the early sensitive period of his first 1,000 seconds, he is in separation with his mother. Having sensitive and loving parents override many other interventions for better neonatal outcome. The best way to support this parental sensitivity and love is to keep the family together and to see parents as partners in the care from the very start, where they play an active role in providing emotional, social, and developmental support for their baby. The concept of infant and family-centered developmental care falls into place with no need to compromise on life-supporting therapies and safety for babies and mothers when skin-to-skin contact and couplet care is implemented and planned for from the birth of the baby, keeping mothers and babies always together. Zero separation is a vision, a mission, and a goal for all newborns. Depending on our system, the preparation, our equipment, and capacities, we sometimes need to separate the baby and the mother for life-saving interventions that were not planned for or prepared for. Sometimes we can't do perfect, but we can always do something. The girl to the right was born at term age and unexpectedly suffered from shoulder dystonia. She had no vital signs at birth. She was stabilized in another room and then brought back to the mother for 15 minutes of skin-to-skin contact before transfer to the NICU. The very preterm girl in the incubator was stabilized separated from the mother, who was sedated during an emergency C-section. With new ways of working, we can minimize events of separation and make needed separations as short as possible. And as soon as the situation on our patient is stable enough, we plan for skin-to-skin contact, connection, and breast milk. In our Swedish experience, the change of systems toward early skin-to-skin contact and zero separation started with education in infant and family-centered developmental care, IFCDC for short. In many Swedish units, this has been training according to the Newborn Individualized Developmental Care and Assessment Program, NIDCAP. With champions in IFCDC trained in observing infant behaviors and needs and in supporting families, we see a change in mindset, a change in culture and in systems for a nurturing care and environment for infants and mothers and the rest of the family. When reading about the trajectory of the research field of immediate skin-to-skin contact, it seems to me that Ann-Marie Widström in Sweden was one of the early pioneers in looking at medical and physiological outcomes from skin-to-skin contact when she was studying breastfeeding behaviors in newborn term infants. From the continuation of this work, we have reached a consensus that all term infants should be in direct skin-to-skin contact and left undisturbed for at least the first 1 to 2 hours after birth or until first breastfeeding. However, this recommendation is still not fully implemented, and intensified work on routines and mindset is needed. Nils Bergman published his well-known RCT on immediate skin-to-skin contact for preterm infants already in 2004 and found this to be feasible and that low birth weight infants from 1200 gram increased their physiological stability in immediate skin-to-skin contact. The interest for this new way of working has clearly increased the last few years, and we see many research groups exploring the field. In 2021, Gupta presented a review on early skin-to-skin contact defined as initiation within the first 3 hours. There were only 30 studies that were suited for review. They found strong evidence for positive effects on stabilization of physiological parameters, breastfeeding, and bonding. In April 23, only 2 years later, 137 studies were reviewed in this very didactic review on skin-to-skin contact directly after birth, defined as within the first hour. It presents the strong evidence for the new WHO recommendations, as well as offering practical guidelines. All mothers and all babies above 1,000 grams should have immediate skin-to-skin contact after birth that is safe, postpones routine care, is uninterrupted and continuous, allowing progression through the newborn's instinctive behaviors. The expert group highlights the considerations, ethics, and risks of not offering immediate, continuous, and uninterrupted skin-to-skin contact, and especially in the context of the Convention of the Rights of the Child. The very large IKMC study has been transformative in the knowledge and evidence for immediate skin-to-skin contact for preterm and low birth weight infants. It is an international multi-center RCT on 3,211 preterm infants with birth weights of 1,000 to 1,800 grams. It was run in low and middle income settings in India, Malawi, Ghana, Nigeria, and Tanzania. The intervention group had 17 hours per day of skin-to-skin compared with 1.5 hours in the control group during the first days. To be able to do this intervention and having the mothers together with the infant, the unit also had to implement mother-newborn couplet care. This work was published by the WHO Imediate KMC study group in May 21, showing a 25% reduction in neonatal mortality, with the primary driver being lower rates of invasive infection. Here you see Nils Bergman, Björn Westrup, Siren Rettedal, and Agnes Linnér, who all were very important in the IKMC trial and in the Scandinavian IPISTOSS study that we will talk more about. For infants below gestational week 28 or 1,000 grams, there is a very limited number of publications on immediate skin-to-skin contact. Early initiation of skin-to-skin contact for extremely preterm infants have been said to be everything from the birth moment to first day or up to 3 weeks of age. Victoria Karlsson and the group in Uppsala have shown that initiation of full skin-to-skin contact is safe already at day 2 to 5, also for the most immature infants of 22 to 25 weeks of gestation. And Charlotte Casper and the group in France showed that also for this group, the benefits of skin-to-skin contact are dose-dependent. Catherine Mehler and the group in Cologne initiated skin-to-skin contact for the infants from gestational week 25, as early as after the initial stabilization at approximately 45 minutes after birth, and with a duration of 60 minutes. And in several publications, they have presented very important findings from this intervention. There are several publications of what is called delivery room cuddling. Having the actual skin contact or not is of course very important, but in some situations the skin contact is not feasible, and then supported and facilitated closeness between parents and newborns during and directly after the initial stabilization is important and should be incorporated in clinical guidelines. Several different British groups present positive psychological effects on parents from holding their infant from week 22, including infants with malformations, formations, etc., for only 5 to 10 minutes just before transfer to the NICU. And Drs. Clarks and Cowley and their team in the UK have made a helpful algorithm for delivery room cuddle for extremely preterm infants. Efficient teamwork, good planning, clear communication, and mobile equipment will cover the increased risks the smallest babies have for hypothermia, respiratory instability, and hypoglycemia, according to this team. The group concluded that this way of working was feasible and safe, irrespective of gestational age of the newborn. The same algorithm should be possible to use in other situations with extremely fragile newborn, like asphyxiated infants, infants with malformations, and need of intensive care or early surgical interventions. For less vulnerable newborns, this could be a helpful first small step for the unit towards full implementation of skin-to-skin contact in the delivery room. Here we see the IPISTOSS team, the immediate parent-infant skin-to-skin study at Karolinska, Sweden, and Stavanger, Norway. Nils Bergman and Björn Westrup took the initiative for this study and actually also for the IKMC study that was later run by the WHO with support from the IPISTOSS team. At the Karolinska site, the clinical work was mainly done by Agnes Linnér, Cyril Liljesköld, and myself, Stina Klemming. The immediate parent-infant skin-to-skin study randomized 91 very preterm infants before birth to either immediate skin-to-skin contact or conventional care in a cot or an incubator during the first 6 hours of life. In this publication of the primary outcome, we report that the 46 very preterm infants who were randomized to immediate skin-to-skin contact with the parent the first 6 hours, here in red line, stabilized the cardiorespiratory system better and faster during these 6 hours of life than the 45 infants that were cared for in an incubator, the blue line. This was according to the SCRIP score with heart rate, respiratory pattern, and need of respiratory support with oxygen and CPAP, a finding that showed that the improvement in SCRIP score was clinically relevant with improved clinical stability was that the skin-to-skin group needed central lines significantly less often as conventional care infants, with 6.5% compared to 22%. It is very important that we can minimize invasive and stressful procedures, and thereby the effect of the initial intervention is further increased. We also published a secondary outcome on temperature, concluding that both groups had normal temperature and that skin-to-skin contact seemed to protect against hyperthermia from a heater. Again, the intervention group is in red. Parents' experiences were presented in this publication by Siri Liljeskiöld, concluding that parents feel that the skin-to-skin contact enhances connectedness and bonding and was empowering for parents at the same time as they felt vulnerable in this situation. It was also concluded that mothers desired to be with their baby from the start and that there was a need for mother-newborn couplet care. More publications will follow from IPISTOSS, for example, on breastfeeding, social connectedness and bonding as measured by PISERA, and the 2-year follow-up data. We conclude that immediate skin-to-skin contact is feasible and may be the desirable standard of care for very preterm infants. We will now go through the clinical practice from the IPISTOSS. Stabilization and newborn care in separation in skin-to-skin contact or close to the mother need to be planned well, but is really not different from our regular care. The care is the same, the place is different. We need mobile equipment and NICU staff to be in the delivery room. We need the equipment to be connected to gases and power supply. Respiratory support and monitoring, as well as nasogastric tubes, feedings, lines, and fluids are planned as usual. Only the place is different. Same goes for temperature control, and as always, we need to plan and act thoughtfully to keep the baby warm. We need to inform and support parents, to keep a calm atmosphere, and to take photos. The most important thing for newborn care in the delivery room is good planning, clear leadership, and communication for safe and optimal care. So things are pretty much the same. We need to go mobile. We need mobile skin-to-skin compatible equipment like this wheelchair with everything we need mounted. Respiratory support with RPAP, TPs, CPAPs, ventilator, whatever we choose. Gas bottles, humidifier, battery, monitoring devices. APGA clock, nursing gear with skin-to-skin shirt or binder, nasogastric tube, lines, medicines like surfactant, and other equipment for the care of the newborn. We also need an adult bed or wheelchair and maybe a stabilization platform or trolley. And the new way of physiological-based cord clamping requires changes in practice and the development of equipment that support resuscitation procedures close to the mother. This is a game changer and all in line with the concept of separation. When changing practice for cord clamping, at the same time, we can add in opportunities for skin-to-skin contact. To the left, we see how a stabilization trolley can be used when caring for a term newborn in immediate skin-to-skin contact with the mother during a C-section. And in the middle, we see the same baby in a transfer in skin-to-skin contact with the mother having respiratory support with CPAP. And to the right, a transfer with the parent in a wheelchair. This boy was born with a cesarean in week 28 plus 2, weighing 1,052 grams. He was put immediate skin-to-skin with a surrogate, the sister of the mother, and got all the conventional care that prematurely born infants in our setting usually gets, with nasal CPAP, monitoring, and temperature control. The place was different, the care was the same. You see how we put the electrodes on the back since the infant is in either a tucked prone position or in side lying. We put the pulse oximeter sensor on the right hand and we cover the baby with a merino wool blanket as soon as possible. We hold the nasal CPAP, let the infant adapt as undisturbed as possible for a while, and we assess breathing movements. I asked the aunt if she felt the boy breathing, and yes, she did. She felt he was breathing well. We put an elastic band on the cord instead of the hemostatic forceps. We give vitamin K, and at the same time, we do a quick assessment of genitals and anus, not to get any surprises later on. We cover the baby well with wool blankets and keep warm towels around, protecting from bright light and too many sensory stimuli for the baby to regulate well. When the situation feels stable and calm and baby is breathing well, here at 8 minutes of age, We put the cap for the CPAP on. We put the wool cape over the body of the baby, smooth along the infant's body, and over that comes the KMC binder or tube carrier. Over this, we put a heat-preserving blanket, and we're then ready for transfer, or just to stay in the delivery room. We will now see 10 seconds from a delivery in Stavanger, Norway during the IPISTOSS trial. And as you could see there, the wool cape was not there, and there was a polyurethane bag instead. This can be done in different ways. This is possible also for twin birth. After the cord is cut, twin 1 is put with the father and receives care with nasal CPAP, monitoring, and eventually also a nasogastric tube and a peripheral line. Twin 2 stays with the mother and receives care there. Care is the same, the place is different. As we see here, we have double sets of mobile equipment, and initially we had 2 neonatal nurses. One nurse stayed with the family in the delivery room for 2 hours. And mind that this was 2 patients, 1 nurse for 2 patients. So staffing is pretty much what we have in the neonatal unit. 45 minutes after the delivery, the mother started to hand express milk for 30 minutes, and the amazing amount of 20 milliliters could be shared by her twin boys. Little Liv here was born in week 28 and 4 days, weighing 965 grams. With our mobile way of working, she was put in skin to skin with her father at 8 minutes of age and was reunited with her mother like this when the mother was still on the operating table. Safety precautions for the mother and the newborn are essential. As always, we need a backup plan and continuous communication in the NICU team and with the obstetric and anesthetic teams. We need to be mindful that the obstetric team isn't hindered in their work by the presence of the neonatal team and our equipment. Here, the mother was bleeding heavily, so the infant was moved to the father for evaluation and care of the mother. The father was already prepared that this could be needed, and he was dressed with a KMC binder, a tube carrier. And we had the wheelchair for the father ready in the room. Same goes for preparation for the possibility that stabilization is not possible, comfortable, or safe in skin to skin. This girl was put immediately skin to skin with her father after a C-section in week 30+1. She did not breathe and got a few puffs with the T-piece, but was then moved to the open incubator for further stabilization, after which she could safely be put in skin to skin with her father again. And this boy, born vaginally at week 29, was in need of stabilization, including intubation and surfactant administration, before he could be put back in skin to skin, and this time with his father. If we stay in the delivery room until the mother can be moved, we can transfer the mother and the baby to the NICU together, using a bed for the mother, as in the pictures below. When this is not possible, we can transfer the baby with the father, the parent, the other parent, or a surrogate after a delivery room cuddle or period of skin-to-skin contact with the mother in the delivery room. The mother comes when stable enough according to local guidelines. This is Nurse Bergman in Nigeria during the IKMC trial. This mother has her infant in a KMC shirt for continuous skin-to-skin contact. For safe, immediate, and continuous skin-to-skin contact, we recommend a binder of some sort to secure the airway and prevent obstructive apneas, and for parents to do continuous skin-to-skin day and night, also when sleeping themselves in a safe way. To the left, you see a newborn in unsafe skin-to-skin contact, suffocating and experiencing sudden unexpected postnatal collapse, without parents realizing, and the father actually taking this picture. And in the picture to the right, you see a mother in safe co-sleeping with her infant, secured in a binder and connected to a monitor. So safe skin-to-skin contact includes sensitive and optimal medical and nursing care, secure airway, and a sniffing position, and with it secured with a binder. temperature control, and postural support, as you see in the small pictures to the left. The infant should be either in a prone tucked position with the head only carefully to the side, and a supported position with shoulders rotated inwards and the back curved avoids maximal rotation of the head. Or the infant is in a supported sideline position. It is important that the position is comfortable for the infant and for the parent, since we want to support them to have skin-to-skin contact as continuous as possible. For this to be possible, we also need the system to support this with mother-newborn couplet care, which is a concept where care for a sick or preterm newborn is provided in close proximity to and coupled with the care of the mother. The couplet care is defined as the time from when the mother gives birth of the baby until the mother is discharged. After discharge, the mother as well as the other parent and family members should be able to continue to stay with the baby until the baby is discharged. And this is according to other principles of infant and family-centered developmental care. So we only call the care couplet care when we have two patients in need of hospital care and that their care is coupled for them to be together. The location of the care of the diet is decided according to a medical assessment of each patient, usually determined by the patient with the most complex medical needs, the local context, and the flexibility within the system. For safe care of both patients, we recommend that the level of care, the location of care, and the tailoring of care is decided by the team according to risk assessment and the specific local couplet care guidelines. For most mothers for infants in need of neonatal care will have a low-risk assessment and can be transferred to the neonatal unit for couplet care soon after giving birth. For sick mothers and mothers with complications, we need to individualize and tailor care for the mother for her to be able to be cared for in the neonatal unit. Most of all, we need a flexible and mobile staff from the obstetric and anesthetic departments. If the care of the mother for a few hours is needed to be located in the operating theatre, the post-operative ward, or if the mother needs care in the adult intensive care unit or any other adult department, a flexible way of tailoring care is instead needed from the neonatal team so that the infant can be cared for together with the mother in these locations. So the newborn is assessed accordingly to decide needed level of care, location of care, and how care can be tailored for non-separation of the diet. In all Swedish birth hospitals, moderately sick and moderate to late preterm newborns, instead of being moved to the neonatal unit, can receive couplet care with their mother in the delivery department or the maternity ward, or the surgical department. Several units in Sweden have made detailed guidelines for the risk assessment, for tailoring of care, and for the both separate and shared responsibilities for staff caring for both patients. If the mother needs bedside supervision and complex treatments by the obstetric and anesthetic teams, she might not be able to be cared for in the neonatal unit at the moment. This could be because of eclampsia or severe preeclampsia, large bleedings, hemodynamic or respiratory instability, or other reasons for care in the adult ICU, or more infrequently contagious disease or severe psychiatric illness. Most often the duration of a severe condition for a mother is short, and with frequent re-evaluations of her condition, care can be coupled with her baby in the neonatal unit or pediatric unit as soon as possible. Here is an example of a flexible system reinventing how care can be organized. This mother had complications to anesthesia during an urgent C-section and needed observation and treatment in the adult intensive care unit. The diet was transferred there in skin-to-skin contact. Because of a tachypnea of the newborn, the neonatal staff followed, and you see the neonatal nurse to the left, to observe the infant for cardiorespiratory stability and for glycemic control, since she was a large baby of 4.6 kilos. The neonatal team brought equipment for intensified care of the infant if needed. So all staff categories have to be prepared to walk that extra mile. We actually have to move ourselves to the place where our patient is cared for. For the obstetric team, this is most often the neonatal unit, but can be other pediatric units like intensive care units for heart defects or for other surgical needs. Neonatal staff need to be flexible and be able to care for babies in the birth room, the postnatal ward, postoperative ward, or as in the lower picture, the adult intensive care unit, to where the neonatal team brought this girl, born in week 33, to her very sick mother. As part of requirements and routines for safe and flexible care for mothers being cared for in the neonatal unit, there is a need for availability of both midwives and obstetricians whenever necessary and for daily rounds, like here a medical round by the obstetric team in a couplet care unit in New Delhi, India. For urgent situations, we need special alarm systems for both patients to alert staff with the right specific competence, and we need emergency equipment for both patients in every location where babies and mothers are cared for. And this is actually true also for units that did not yet implement couplet care. This mother was moved from the operating room and directly to the birth room she was in before the decision of an emergency C-section. She still has a spinal anesthetic, and the anesthetic nurse comes along for safe care of the mother. The neonatal team follows to care for the moderately sick newborn in need of respiratory support with CPAP, and the baby is, as you see, in skin-to-skin contact with the mother on her chest. This routine to skip the postoperative ward is practiced in several units in Sweden and has been supportive for non-separation. This is the same mother-newborn diet. The mother is treated for a sepsis, has 2 peripheral lines, IV fluid and IV antibiotics. She has continuous cardiorespiratory monitoring, and her blood pressure is measured every 10 to 15 minutes. She still has a spinal anesthesia. The baby is 30 minutes old, has respiratory support with CPAP, and has been in skin-to-skin contact with his mother from birth. We see the teams working together. The grandmother was with the mother during the birth and the C-section as a surrogate and companion instead of a partner. 45 minutes after birth, also the grandfather arrived to congratulate his daughter and welcome his grandchild. Safe couplet care with a neonatal nurse for the sick newborn and a midwife for the sick mother, and true family-centered care. This was a regular clinical situation at the neonatal unit in the perinatal department, Capio Sankt Göran in Stockholm 2 months ago. When caring for a mother in couplet care in the neonatal department, we need space for at least 1 adult bed. This should be a hospital bed with removable headboard in case of an emergency for the mother. Preferably, we want hospital beds for both parents for logistic flexibility. We need large enough family rooms with private bathrooms for good accessibility, as well as family kitchen and food and other services for the mother and the other parents. And this can, of course, be arranged in different ways in different settings. These pictures are from 5 different neonatal units in Sweden designed for couplet care. In addition to the adult bed in close proximity to the baby, families with the baby in the high intensive care might need a separate family room for a few hours of undisturbed sleep from time to time. They can then take turns in being with the infant. Mother-newborn couplet care can be implemented in any setting without extensive remodeling and special NICU design. Single family rooms are good, but not necessary for the couplet care concept. The bed for the mother and the combination with continuous skin-to-skin contact is the most important change, as we see here from couplet care units in India and Tanzania. For smooth and flexible care, we recommend education cross-training for all staff. For first aid care of the other patient in the diet, annual training and adult CPR is a requirement for all staff. Neonatal staff also need to know how to help with assessment of the mother, to take a blood pressure, empty a urinary catheter bag, check an IV, and maybe after training, check bleedings and uterine tone. Nurses and doctors in the delivery unit, the post-operative ward, and the adult intensive care unit should know how to ventilate a newborn and how to alert the neonatal team. They could also help to monitor a newborn. To support breastfeeding initiation and early and ongoing frequent expression of colostrum and breast milk is very much a perinatal team effort and a shared responsibility by all teams. Here are two examples of how nursing care is organized to keep the diet together. To the left, you see a mother with insulin-dependent diabetes and preeclampsia being cared for in the neonatal unit. A midwife, who is also a NICU nurse, checks on the mother's insulin glucose infusion and on the infant born preterm with a cesarean a few hours earlier. In the picture to the right, we recognize the term baby in need of respiratory support, with his mother treated for sepsis and observation after C-section. The neonatal nurse looks after the boy, and the midwife checks on the mother's vital parameters. So instead of having one super nurse, we have two nursing teams working together. In a survey in April this year, the majority of units in Sweden and Finland reported that couplet care was implemented in the neonatal unit to some degree. Only a few units have a full implementation of the concept in the neonatal department. We have identified 4 different organizational models of mother-newborn couplet care in Sweden and in Finland. We are now working on national guidelines for Sweden on both immediate skin-to-skin contact and mother-newborn couplet care. And this is done in all the national societies for specialists in the different fields. So the Neonatal Society, the Society for Midwives and Neonatal Nurses, obstetricians, and nurses and doctors in anesthesiology. This will be very exciting. We will now go through the 4 different organizational models. So model 1, this organizational model of separate units working in close collaboration for care of the 2 patients is actually the most frequently implemented model for couplet care in Sweden and Finland. This model keeps the expert care in separate departments. Midwives, maternity nurses, and obstetricians employed in the maternity department care for the mothers, sometimes also in collaboration with the anesthetic department. NICU nurses and neonatologists in the NICU care for the babies. Many things can be run as previously, and the departments are not merged. Maybe this is the reason that this model is often used as a first step when implementing couplet care in already established units. It has many challenges. The biggest, of course, are the collaboration and logistics between the separate units, and many times the implementation is inconsistent. Model 2. In this organization, midwives are employed in the NICU, caring for the mothers together with the NICU nurses, or actually also being a NICU nurse, as a primary care team of the diet. The medical teams, the doctors, are still traditionally divided, and collaboration can still be a challenge. Obstetricians need to trust staff from the NICU to care for their patients. It can be difficult to cover the needs for midwives or maternity nurses and to organize rotation to the delivery department for midwives. This is a fragile system, but worked well for 10 years at Danderyd, Karolinska, Stockholm during the years 2003 and 2012. Model 3, this model of couplet care with more and more specialized newborn care in the maternity ward, has gradually been implemented in every unit in Sweden and Finland. One driving force have been the lack of beds in Swedish and Finnish NICUs and the difficulties to reach a full implementation of couplet care in the neonatal departments. The last 5 to 10 years, we have seen how more and more specialized care for moderately sick and late preterm infants is offered outside the neonatal unit, in the birth room, the post-operative room, the maternity ward, or even in the family's homes, with home visits for both the mother and the baby. Conditions for the baby can be late preterm birth, feeding difficulties, hypoglycemia, phototherapy, neonatal abstinence, mild transient tachypnea, even with need of short treatment with CPAP, nasogastric tube feeding, and sometimes even IV antibiotics. Model 4. This is for me the most interesting model, a department of perinatology with obstetric, neonatal, and possibly also anesthetic and adult intensive care in one organization. This organization has amazing possibilities. It seems to be preferred when building a new unit. This model was tested in Stockholm a few years ago. It was a beautiful, fully equipped birth unit for mothers and babies. Systems and routines were flexible, and it was very popular amongst patients and staff. Because of some other organizational difficulties, it became expensive and could not continue. In April this year, a new perinatal department with this organization opened at the Capio St. Göran Hospital in Stockholm. Should this be the gold standard? This is really to organize healthcare around the inseparable mother-newborn dyad, as in the WHO vision. We want to point out that the choice of organizational model is based on very many factors, since change in one system often affects others. You might have to address the challenges with your local reimbursement system in order to safeguard the financing of your departments, for example, by contracts between the different departments. Our experience in Sweden for implementation and maintenance of mother-newborn couplet care fits well with this model for translating neurodevelopmental care policies into practice by Véronique Piera, neonatologist and NIDCAP professional in France. It is very challenging to find the optimal organization to maintain communication and cooperation between separate departments, and logistics and resources are often discussed. My experience is that with education in IFCDC, Infant and Family Center Developmental Care, we see the needed important shift in mindset and in culture, which makes all the other challenges easier to overcome. If we get hospital leadership and political leadership to grasp the importance of the concept, we can also get the needed resources. The importance of culture change, collaboration, coaching, and capacities has also been described in this paper about parent-infant closeness. Benefits for mother-newborn couplet care for sick and preterm infants and their mothers are many, but publications are few. The Stockholm Family-Centered Care Study was partly a comparison between a couplet care unit at Danderyd and conventional care in 2 other sites. We have unpublished data from a QI project at Karolinska, and there's one publication from Canada and one from the Netherlands. And we can now add the IKMC trial to these experiences. We have seen earlier breast milk production, higher incidence of breastfeeding, lower blood pressure, and less reported pain in mothers, lower stress and anxiety for mothers, and calmer situation for fathers. Mothers and babies showed in the Stockholm study improved physiological mother-infant synchronicity measured by saliva cortisol. And that was actually a measurement of infant and family-centered developmental care. Infants being with their family from the birth had shorter length of stay, most significant for the smallest and sicker babies in the IKMC trial, with continuous skin-to-skin contact, facilitated by couplet care. Mortality was reduced by 25%. With immediate skin-to-skin contact and mother-newborn couplet care, we see a new parental behavior with increased participation in care, as well as increased and even continuous skin-to-skin contact day and night. And during the years with mother-newborn couplet care at Danderyd Karolinska, we saw increased mean time of skin-to-skin contact to 8.5 hours per day, which was higher than periods afterwards, actually. In a recent study on initiation and duration of skin-to-skin contact for very preterm infants in Swedish NICUs, regional differences were seen. And according to an eyeballing of this study, there was a trend that the units with the well-implemented couplet care have earlier initiation and longer hours of skin-to-skin contact. So My conclusion is that mother-newborn couplet care is a must to support continuous skin-to-skin contact for 8 to 24 hours per day as recommended by the WHO for all infants above 1,000 grams. And we can easily see how it is as important to avoid separation for the most immature infants. When looking at neuroprotective bundles for the most immature infants, like this from the University of California, San Francisco, UCSF, we could easily add the scientific rationale for skin-to-skin contact. The driver separation leading to toxic stress as described by Niels Bergman in 2019, and the intervention would be immediate or early skin-to-skin contact, continuous skin-to-skin contact, and non-separation with mother-newborn couplet care implementation. I also thought of some indicators for this implementation. Time for skin-to-skin contact initiation and duration, place of care or minutes of separation, the first 120 minutes, time for the first colostrum by mouth, skin-to-skin measured as hours per day, maybe with the parental diary, number of couplet care mothers and days that they were cared for, and length of stay, breastfeeding outcomes, maternal outcome like blood pressure, pain, well-being, and total experience of care, and of course other measurements relevant to your setting. Measuring the time spent in skin-to-skin contact can be done by a simple diary where parents themselves draw a line. In this diary, we added time spent in direct closeness bedside, not in skin-to-skin, and togetherness in the room, as well as time of separation, for a total score of closeness during the day. Full closeness in skin-to-skin contact over 24 hours gives a score of 72. And we see in the example we have 49. Full closeness in continuous skin-to-skin contact is possible. This is Benjamin. He was born vaginally in week 32 and 1 day and was put immediately skin-to-skin with his mother. And there he stayed until 7 hours of age when he was moved to his father. And on their own initiative, the parents started to take turns, and Benjamin was cared for in continuous skin-to-skin contact with his parents for the first 7 days and nights. The parents described their experiences on immediate and continuous skin-to-skin contact in the Developmental Observer and in the 2023 Swedish Conference on Ultra-Early Intervention. And we are so grateful for getting the opportunity to be with our son from the very start, to be able to be close to him all the time, never to be separated, and to hold him skin to skin. Our only fear now, when we know that other possibilities exist, is that someone somewhere will have to be cared for according to routine care in an extremely old-fashioned way, and will have to be separated from their little one. And if a parent's love and closeness is not paramount in a child's well-being, then what is? We will now listen for 3 minutes to the parents of Benjamin, and this is a shortened version of their story at the Swedish Conference on Ultra-Early Intervention in March this year.
A small child needs its parents. A tiny child needs them even more. And if a parent's love and closeness aren't paramount in a child's well-being, then what is?
The perfect and tiny little boy, and was immediately placed on mom's chest. There were machines and hands everywhere, and although neither of us could really see him, it was comforting to know that one of us could actually feel him.
I could feel him. I could follow the nurses' faces and facial expressions as if they were me they were working on. A strange calm settled in.
For 7 hours, Benjamin lay uninterrupted on his mother. All the necessary tests were performed and checks were carried out where he lay. It felt incredibly natural to have him on his mom's chest. We have promised our boy eternal love and security. We have promised him never to let go of his hand.
Without a word, we divided the day into 8-hour shifts, day and night, that our boy should have us all the time, as he knows nothing about the world. We must help him. We are the adults, and he is the child. The benefit for Benjamin was the most important for both of us. Zero separation facilitated the healing of our wounds. Open wounds that we had carried with us into this pregnancy, but also all the wounds that had arisen during the pregnancy with Benjamin. Not daring to really be happy either, because life is so fragile. The feeling of having failed the pregnancy is overshadowed by the feeling of being able to care for your child.
Being someone's most important person for real and from the first second is comforting. Not having to leave him had a greater effect than we dared to believe, that we did everything in our power to give him the absolute best. Makes us today look back in our period at the NICU with warmth, gratitude and some joy.
We are sure that the feeling of holding Benjamin skin to skin helped us to find inner peace. Being able to care for your child skin to skin when there is a medical possibility feels like such an obvious thing. We are so grateful for the opportunity to take care of our son from the very beginning.
Contributors of knowledge, inspiration and support for this talk and for the work I have been part of are the NIDCAP Federation International, the IPISTOSS team at Karolinska and Stavanger, the group for iSSC at the Swedish Neonatal Society, the Lund-Malmö NIDCAP team, the Capio St. Göran department and all the families. I would also like to mention the organization for the Swedish Conference on Ultra-Early Intervention and the YouTube channel NIDCAP Sweden, where you have free access to the conference Always Together from March this year, with fantastic presentations on couplet care and early skin-to-skin contact, as well as all the previous conferences since 2015, and a special playlist on other video presentations on our work from IPISTOSS. Thank you for your attention.